All right. Well, it is 12:02 and I could fill our hour with my introduction. So, Larry, are you okay with us to just go ahead and get started?
Yeah, please.
Okay, so we are so fortunate today to have Dr. Lawrence Sperling, lots of letters coming, MD, FACC, FAHA, FACP, MASPC, to give our grand rounds today. He is the founder and was the director of the Heart Disease Prevention Center at Emory from 1997 to 2019. He's originally from New York, but as we were talking about earlier, he is like our previous Grand Round speaker, Dr. Del Rio, as someone who we feel is Emory grown. So he received his undergraduate degree from Emory College. And at the time, there was a special program that he was accepted into where he was accepted as an early college sophomore to Emory University School of Medicine's early acceptance program. So he graduated with his MD from Emory in 1989 and then subsequently completed 8 additional years of training at Emory, including a residency in internal medicine, chief year at Emory University Hospital, and an NIH-supported research fellowship in molecular and vascular medicine, followed by a clinical fellowship in cardiovascular diseases. Dr. Sperling is currently the Katz Professor in Preventive Cardiology at Emory School of Medicine and Professor of Global Health in the Rollins School of Public Health. He's also served as the Executive Director of the CDC CMS Million Hearts Initiative from 2019 to 2024. He served as the President of the American Society for Preventive Cardiology from 2014 to 2016, and as a member of the Writing Committee of the 2018 ACC-AHA Multi-Society Guideline on the Management of Blood Cholesterol. He's currently an associate editor for the American Journal of Preventive Cardiology and chair of the World Heart Federation Roadmap for Cardiovascular Disease Prevention among people living with diabetes. He's also served on the writing committee of the AHA Cardiovascular-Kidney-Metabolic Health Initiative, which has brought forth the importance of an integrated approach to prevention and treatment in this high-risk population. He founded in 2004 and directs the only LDL apheresis program in the state of Georgia. He was the PI for the Natural FH Registry site at Emory, and he's received numerous awards for excellence in teaching as well, including 4 Golden Apple Awards and the Dean's Teaching Award. And in addition to this, he received the Emory School of Medicine Alumni Award of Honor, the Right Care Leadership Award for Precision Medicine in Heart Attack and Stroke Prevention, and the CDC Shepherd Award for Original Research Publication. Many other awards also. He's authored over 450 manuscripts, abstracts, and book chapters. He has delivered invited presentations on every continent except for Antarctica. And he has taught many of the attendees in the audience on the Hearst Cardiology Service and in clinic in his many years of clinical service. And so we're so lucky to have him today to talk to us about the focus on CKMH to prevent cardiovascular disease. Dr. Del Rio, anything else to add? Hold on, you're on mute.
I've known Larry for many years, and for those that don't know him, Dr. Sperling has had a unique and as Karen mentioned, a markedly versatile career over 3 decades. He's been a pioneer in preventive cardiology. He's a national and global leader, a clinician educator, a mentor, a researcher, and his numerous accomplishments and commitment to prevention, to health equity, and his leadership skills have really made him a recognized leader and someone that we are very proud of to have here at Emory. So I'm looking forward to his grand rounds. And again, for the residents and other young people in the audience, Larry is just an example of the kind of career that you can have that can not only have a local, but a national impact and a very significant impact in improving lives globally.
Thank you, Dr. Law, Dr. Del Rio, for that wonderful introduction. Equally grateful to be part of the Emory community, a really special place over the 3+ decades that I've been, a trainee and a faculty member. So I'll be talking about an important focus. This is an initiative through the American Heart Association, the CKMH initiative, and so you'll be learning what CKMH stands for, the Prevent Risk Calculator. But most importantly, today I'll be focusing on opportunities to advance cardiovascular disease prevention. I have no conflicts related to my presentation today. Importantly, my comments today reflect my specific comments and not those of the organizations I work for, work with, or serve. So as an overview of what I'd like to be covering during my grand rounds, I'll start out with a little bit about my journey. I really enjoyed Dr. Del Rio's journey and sharing his background last week. And I've known Dr. Del Rio for about 3 decades, and I learned a lot about him during his presentation. We'll leap into a case that's going to be very relevant to today's discussion. I'll provide an overview regarding cardiovascular disease mortality on a national level and global level, introduce you to the concepts of cardiovascular risk assessment. Sorry about the little bings, but I had to log in through a different mechanism today because of some systems challenges. But anyway, we'll talk about risk assessment. We'll talk about cardiometabolic health and cardiometabolic disease, the CKMH initiative, Cardiovascular-Kidney-Metabolic Health Initiative, and then the Prevent Risk Calculator. So first, my journey. And I really would encourage each and every one of you to get to know your colleagues well. We have incredible colleagues here at Emory, and each and every one of us have our own individual journeys. And so take the time to get to know one another beyond, just working on service or working in the clinic or even doing research together. Let's get to know each other. So my journey, my family on my dad's side comes from a little village on the bank of the Dniester River in what is now the Ukraine. I'm only really the second generation on my dad's side of the family in this country. A decade ago, I was fortunate enough to visit this little village, something I would unlikely be able to do today. And then my journey into cardiovascular disease prevention. Many of us are motivated in our careers either through life experiences, family experiences, something that really drives us. And when I was young, my grandfather, you can see the water skier on the left of this slide. My grandfather was very vibrant, really such an important part of our family, very athletic. And in his 40s, he had a heart attack. And he was searching for options. The famous surgeons, Denton Cooley and others, declined his eligibility for surgery. And ultimately, my grandfather had surgery with Walton Lillehei, the inventor of the heart-lung machine, a procedure called the Weinberg procedure, implantation of the internal mammary artery into the left ventricular wall. And then at a young age, my grandfather died, and it really taught me how heart disease can take away, those that we love at an early age. Well, Dr. Law and Dr. Del Rio mentioned I've been at Emory for many years. I was an Emory undergrad. If you look at this slide, the upper left-hand panel, I was a Dooley's bodyguard as an undergraduate. And the upper right-hand panel, if you focus in on number 23, I played on the first Emory basketball team. And so if you're wondering why LeBron James and Michael Jordan picked number 23 for their uniform, now you know. I didn't make it in the NBA draft, and so my backup plan was to become a preventive cardiologist. Well, my career has really developed in many different domains. My training was in molecular and vascular biology, but my career developed into focus on cardiovascular disease prevention, and then ultimately now in population health, global health, and public health. And for our trainees or even young faculty, none of this was by design. So be open to possibilities. When opportunities arise and a fork is in the road, you have to make an educated decision whether to go for it. And really grateful for all the opportunities I have had. Now, my Emory career wouldn't be possible without many of the Emory giants. Certainly Dr. Del Rio, you can see in the upper right-hand panel. I was a chief resident at Emory University Hospital under Juha Koko. Willis Hurst was a really great mentor and ultimately became a friend and a really special individual to me. Of course, Nanette Wenger. And then at the lower middle panel is Keith Churchwell. Keith was my chief resident, my Grady chief resident. And Keith is now the president of the American Heart Association it's the 100th anniversary of the AHA. And Dr. Law mentioned up until just a few weeks ago, I served as the executive director of a national initiative through the CDC and CMS, the Million Hearts Initiative. Million Hearts is funded by appropriations from Congress, works across all 50 states. Million Hearts is what I call an example of possibilism. The focus on the possibility of preventing 1 million heart attacks, strokes, and cardiac events in our nation through proven and effective strategies, implementation science in the real world. And Million Hearts is focused on building healthy communities, optimizing care. We call this the ABCs, increasing participation in cardiac rehabilitation, but a core focus on health equity. Well, I'm going to share with you my superpower. You know, often people are asked, what's your superpower? Well, my superpower is to surround myself with superheroes. In the left-hand panel is my wife, Dr. Sydney Barr, also an Emory physician. Our two sons, Matthew and Daniel. And Matthew, the one in the Superman outfit, Matthew's about to be married the last weekend of this month. So we're going to come to a case now. And this is a case, I'm going to give you a heads up. I want you to start jotting down this case or just taking some screenshots, because this case, we're going to come back to it. And using this case, we're going to walk through together how to use the prevent risk calculator. And this is a case that is not so uncommon that we see in our state and across the nation. A 59-year-old female postal worker from Cuthbert, Georgia. Dr. Law mentioned I'm from New York. Well, my wife, Dr. Sydney Barr, is from Cuthbert, a very small town in Southwest Georgia, population less than 3,000. The zip code is relevant, so 39840. Asymptomatic cardiac risk factors, hypertension, diabetes, and dyslipidemia, walking a half mile a day, trying to eat better, some pregnancy-related cardiovascular concerns, gestational diabetes, and preeclampsia. So take a screenshot or write this down because we're coming back to it. Well, this patient's primary care physician has been treating her with lisinopril, pravastatin, metformin, and on exam in the office, blood pressure 148/88, BMI 35, an S4 Gallup, trace lower extremity edema, the eGFR 54, urinary albumin creatinine ratio of 100, total cholesterol is 196, triglycerides, I can't see on my screen, but HDL 34, triglycerides 220, HDL 34, LDL 118, A1C of 8.4%. And so take a screenshot or write this down, because together we're going to calculate the prevent 10 and 30-year risk for total CVD, ASCVD, and heart failure. So now an overview. For the past 120 years in the US, cardiovascular disease has been the leading cause of mortality, except for just 2 years. These 2 years were the years of the Spanish influenza pandemic, and racial and ethnic disparities have persisted in our nation for over 5 decades related to cardiovascular disease. In fact, the differential in life expectancy in our country across populations is primarily due to cardiovascular disease disparities. Now, we celebrated a decline in cardiovascular disease from about the year 1960 to 2010, a 50% decline. But in 2010, these rates leveled off and more recently are heading in the wrong direction, especially in rural America, in populations that are certainly ones that are challenged in terms of healthcare access, the healthcare disparities that I mentioned, and we're seeing cardiac events in younger populations than ever before. I do global health, and globally as well, over the past 3 decades now, ischemic heart disease has become the #1 cause of death in the world in what is very much a global economy. Well, just to hit home with this point, and sorry about all the dings again, this was a paper in JAMA just last month. And if you look at these trends over the past 5 years, you can see a decline in Black and COVID-related deaths, thankfully. In green, stroke-related mortalities have gone from number 5 to 4, but at the very top in the mustard yellow, heart disease remains flat, still the number 1 cause of death in our nation. So we're going to dial back to 1961, and in 1961, Dr. William Cannell helped to change our understanding of the causes of heart disease and stroke. And with these 2 words, the field of preventive cardiology was born. Hopefully, many of you can guess what these 2 words are or were at the time. The 2 words are risk factors. So through the Framingham Heart Study, cardiovascular risk factors were identified: age, hypertension, hyperlipidemia, smoking, diabetes, many of the ones that we know well today. And the question today, as we talk about the Prevent Risk Calculator, is why do we assess risk? Why do we calculate risk? It appears to be an economic and efficient method of identifying persons at higher risk. The intensity of the treatment should match the risk of a patient. This goes back to the 27th Bethesda Conference. Clinicians don't do so well guessing. In fact, it's like throwing darts. We don't guess well when we're trying to guesstimate risk. And ultimately, it's that by using risk scores, we have a greater chance of using guideline-directed medical therapy and improving care. Well, this is a key slide, that preventive cardiology efforts begin with risk assessment from the 2013 Risk Assessment Guidelines. For those of you that have been in practice for at least 10 years, hopefully you've become familiar with the pool cohort equation and the ASCVD risk estimator and risk estimator plus, because this is how we've been assessing risk up until quite recently. Well, when we assess risk, there are concepts. One is a concept called discrimination. How well does a risk tool play out? And then the concept of calibration. How well does the risk assessment tool fit the population in which it's asked to assess risk? So of course, in a bell curve distribution, we want to think about a risk tool doing a pretty good job, but in many of our patients, those we will overestimate risk. And in many patients, younger individuals, those of lower socioeconomic status, those with chronic inflammatory diseases, we often underestimate risk. Well, I'd like you to be familiar with the metabolic syndrome. This is the World Health Organization harmonized definition from 2009. Central adiposity, certainly at the core of this syndrome. Variability in the definition of central adiposity based upon various subgroups. And then by definition, to have the metabolic syndrome, you have to have 3 out of 5 criteria: mild elevation of triglycerides, low HDL, elevated blood pressure, elevated blood glucose. If you pay attention to this definition, you're going to start recognizing that you see many, many patients in your office or in the hospital with the metabolic syndrome, and it's a really important discussion to have with patients. A decade ago, we held the first cardiometabolic think tank in the US at the ACC's Heart House in Washington. Over 20 organizations were present, and we described the importance of developing a new care model for the metabolic syndrome. We described stages of risk. Stage A, at risk, and risk might be genetic or community-based or based upon lifestyle behavioral factors. Stage B, you're developing the syndrome. You do not have it by definition yet. Stage C, you have it, 3 out of 5 criteria. And stage D, you have end organ manifestations of this syndrome. And you really want to pair your therapeutic approaches to the stages of patients. A decade ago, we described the importance of moving beyond just a traditional healthcare model, broadening our stakeholders to include public health and our communities. We also described subtypes of metabolic risk: adiposity, vascular, lipid, and insulin-resistant dominant. And if you look at patients developing the cardiometabolic syndrome, there's variability in which of these manifestations are developed in an individual, and there can be overlap of these manifestations. We published this paper in 2019, and Jack and Eric Stahl, who was an Emory resident at the time, was a first author on a Jack paper. So NAFLD, now known as MASLD, is a manifestation of metabolic risk with underlying inflammation, alterations in lipid metabolism, oxidative stress, and insulin resistant. Well, the metabolic syndrome is a classic gene environment behavioral interaction. At the core of this is metabolic susceptibility, underlying atherogenic dyslipidemia. We talked about elevated blood pressure, glucose, development of a prothrombotic and pro-inflammatory state. And we describe what is known as clustering of risk factors. These risk factors do not occur independently. We described in this Jack paper the health disease continuum. In clinical medicine, often we are identifying disease at a late stage. It is really important that we better understand what it means to be healthy with a greater focus on health promotion and disease prevention. Martin Luther King, he described in 1966 of all forms of inequality, injustice, and health is the most shocking and inhumane. We published this paper in Circulation in 2018 that we need to think beyond traditional medical risk factors that we know well. We need to understand and incorporate an assessment of social drivers of health, poor access to care and healthy foods, psychosocial, behavioral, and environmental factors, because by addressing these, we not only understand our patients better, but can really focus on the totality of their care. Well, of course, we want to prevent diabetes. For those that have worked with me in clinic, I often am simultaneously talking to patients about the prevention of heart disease, but also the prevention of diabetes. This is the Diabetes Prevention Program, by which a national program was developed. And in 3,400 patients with prediabetes, they were randomized to usual care in green, to metformin in yellow, and in blue, a comprehensive but very modest lifestyle and behavioral program, walking 30 minutes 5 times a week, a healthy dietary pattern, and losing about 7% of the body weight and keeping it off. I always try to emphasize with patients that the lifestyle and behavioral group was twice as successful as the medical therapy. Well, excited to hear we have a Meds Peds program at Emory now. It's really, really important that we think about health and disease prevention across the life course. The ticking clock hypothesis is this gene environment behavioral interaction. And I'd like to talk about when the gene switch is turned on. It can be through epigenetics, the gene environment behavioral interaction. The clock starts ticking. And unfortunately, that switch goes on in many in our country at ages 6 to 8. And imagine that the clock starts ticking silently until risk factors are developed, and then at some point, overt disease. Well, of course, in those who do develop diabetes, this was a scientific statement we published in Circulation through the AHA. Comprehensive cardiovascular risk reduction is paramount. We do not do a good job with this. And our biggest challenges are not knowledge, it's practice and implementation, and the gaps we have at systems levels. So we want to address risk factors, but we also want to understand and address the social drivers of risk, of health. Well, now that you've had some background, we're going to leap into the CKMH initiative, Cardiovascular-Kidney-Metabolic Health. One of our star fellows, Alex Razavi and Roger Blumenthal from Johns Hopkins, published this commentary this year, and it reminds us that the landscape is changing, our therapies are changing, and our focus is changing. So we now have an increase in prediabetes, longer life expectancy. We are seeing more and more heart failure, a decrease in type 1 MIs, an increase in stroke prevalence, as I mentioned, but we have many new tools in our toolbox. And now we have a new way to conceptualize what is really an epidemic in our country and globally, this CKM axis. Well, through the American Heart Association, a team of us worked for over a year to develop the CKMH initiative, publishing a presidential advisory, 2 scientific statements, and then a paper that developed derived and validated the Prevent Risk Calculator, which we'll talk about. And so what is the CKM syndrome? In a simplified way, the key word is interconnectedness. We are unintentionally frequently developing silos in our understandings of health, our delivery of healthcare, and even our delivery of public health. So this CKM syndrome is a health disorder, and it's interconnectedness at a microvascular and macrovascular level, affecting our heart, our kidneys, our liver, diabetes, and at the core of this is obesity. The pathophysiology is related to excess or dysfunctional adipose tissue, which begins a signaling process at a molecular level: inflammation, oxidative stress, insulin resistance, vascular dysfunction, leading to risk factors, and over time, as I mentioned, to overt organ disease. Well, the burden of the CKM syndrome is increasing. In the CKM initiative, the AHA adopted the stages we described a decade before. So stage 0, you're healthy from a CKM standpoint, no risk factors. You have all the elements of the AHA's Life's Essential 8 describing health. Stage 1, you've got excess adiposity. 2, metabolic risk. 3, subclinical disease, or often measures of kidney dysfunction. And stage 4, overt disease. In this paper in JACC this year, we described the prevalence of the CKM syndrome in the US using the National Health and Nutritional Survey 4 cycles. And even in young adults ages 20 to 44, 80% of young adults in our country have CKM risk, stages 1 to 3, and only 2% of Americans above the age of 65 have no CKM syndrome. Clearly an epidemic. Well, as we think about our individual risk, our patient's risk, we must think about the socio-ecological framework that we all live within environments, our family, our community. Behavior interacts with genes and environment, our communities, and also planetary health. As part of the ACC's expert consensus decision pathway on what we described back in 2020 as novel therapeutic approaches, extending the paradigm of cardiovascular risk reduction to think about agents like SGLT2 inhibitors or GLP-1 receptor agonists, which today are not novel anymore. These are very much in the wheelhouse of our internal medicine specialists and very much in the toolbox of our cardiovascular disease specialists. This is a busy figure. It's not meant to go through it, but I just want to point out that in the scientific statements published by the AHA, we described, first of all, mechanisms of CKM syndrome, gaps in care, but opportunities for screening, prevention, and management across these 4 stages. Well, now that you are familiar with the CKM-H initiative, you're aware that cardiometabolic risk is common. We're going to introduce you to the Prevent Risk Calculator. Before we talk about Prevent, though, I'm going to come back to a slide I showed earlier as a reminder from the 2013 risk assessment guidelines that prevention of cardiovascular disease begins with risk assessment. Well, you may not be aware of the concept of an ROC curve, a C statistic, to be able to discriminate a risk assessment tool. Plotting 1 minus specificity versus sensitivity, essentially false positive versus true positives. The line in the center, that's the line of chance, like flipping a coin or throwing darts. The red curve is like Framingham or a pooled cohort equation. And hopefully our Prevent Risk Calculator is a better test, the dashed yellow line above, up and beyond in the left upper corner here. Well, I want you to remember, though, that risk estimation, no matter how good of a risk tool that has been developed, is based upon group averages applied to individual patients in practice. So this process will always be imperfect. In parallel to the publication of the 2018 cholesterol guidelines, we published this paper. And this was a paper many of us use the concepts in today, the risk assessment tools to guide decision-making and primary prevention of ASCVD. And this is a really useful acronym, CPR. So we want to use CPR to further our risk assessment. Refining risk assessment means you calculate risk, but then personalize risk, and then as needed, you can reclassify risk in patients. We described a concept called cardiovascular risk enhancing factors, presence of early heart disease in a family, metabolic syndrome, CKD, chronic inflammatory conditions like Dr. Del Rio having HIV, and I know you're well aware, but as HIV patients are doing much better from a disease management standpoint, they develop early vascular disease. Other inflammatory diseases, RA, lupus, psoriasis, and then pregnancy-related conditions like preeclampsia, gestational diabetes. Not to say we should be measuring this in all patients, but if you have a C-reactive protein, a lipoprotein delay, an ApoB or an ABI, these can be risk-enhancing factors. Once you calculate risk, you want to focus on absolute risk over a 10-year period. This is the pooled cohort equation. 4 buckets of risk: low, borderline, intermediate, or high. You have a clinician-patient risk discussion, which is a thread of patient-centered, I like to call it patient-partnered care. And then if risk remains uncertain, we can use a tool like a cardiac CT calcium score to reclassify risk and decision-making about intensification of our therapies. Well, the Prevent Risk Calculator, developed by the AHA, stands for Predicting Risk of CVD Events. Very intricate methodology to derive and validate this risk calculator. Very important implications, but the key to the Prevent Risk Calculator is implementation, which is why we're going to walk through a case together so you can calculate risk. Shortly after our publication of the Prevent Risk Calculator, this was published in JAMA, What We Should Know About the Prevent Risk Calculator. And it's a really nice summary by Larkin that we can calculate 10 and 30-year risk of not only ASCVD, like the pooled cohort equation, but total CVD and heart failure. We incorporate kidney and metabolic measures. Race is eliminated in this calculator, but it does factor in social drivers of health based upon zip code as a surrogate for the social deprivation index. The derivation and validation were based on over 6 million individual data sets from 46 data sources, including population and health system data. The goal is to incorporate this risk calculator into the electronic record like Epic, and the model has been available to use since February of this year. Well, coming back to our zip code and the social drivers of health. Here in Atlanta, a very short distance of 7 miles between Buckhead and Bankhead determines a 13-year difference in population-based life expectancy. So health is local, risk is local, and we need to recognize the importance of place. The social deprivation index is a measure that brings in income, education, housing, and transportation, as well as employment. Well, now we get to the Prevent Risk Calculator. So start pulling this up on your computer or your iPhone. You should bookmark it because we're going to use it in just a minute. The online calculator has measures that you're very familiar with from the pooled cohort equation, but also asks about history of diabetes. If we do have an albumin-creatinine ratio, an A1C, and zip code, these are now variables that can be imputed as we calculate risk. So we're coming back to this case from Cuthbert, Georgia, and I'm going to ask you to either start calculating now, or if you jotted down this data or took some screenshots, I'm going to show you the 10 and 30-year risk so you can come back and calculate it again for yourself to be sure that your numbers are consistent with the risk calculator. So we're going to calculate risk, 10 and 30-year risk of CVD, ASCVD, and heart failure. And just as a reminder, 59 years old, a woman, risk factors, has some risk enhancing factors as well, known hypertension, hypercholesterolemia, and diabetes. The variables of blood pressure there are going to be important: BMI, eGFR, urine albumin creatinine ratio, the total cholesterol, the HDL, as well as the A1C. Well, hopefully you have calculated a 10-year risk and a 30-year risk of CVD, ASCVD, and heart failure, which are quite concerning. Above a 20-year risk, at least through the pooled cohort equation, we often refer to as a risk equivalent in somebody that has risk, but are equivalent of somebody living with known heart disease. And you can see the 30-year risk is 50% or greater in this individual. And so this is an opportunity to have a risk discussion, but also to sharpen lifestyle and behavioral approaches to care and therapeutic options. So what is it that we're trying to achieve? Let's think about this 59-year-old patient. We calculated absolute risk. And what we'd like to do is focus on opportunities for risk reduction, absolute risk reduction, and take the curve over the life course from this blue line down to the green line, improving quality of life, and hopefully preventing cardiovascular events. In terms of future directions, the online calculator is now live. Of course, we want to be patient-centered or patient-partnered. We definitely want to implement evidence-based therapies once we calculate risk, and we want to take down the silos we've developed related to just the understanding of risk and risk factor treatment. And this is an opportunity to prioritize and improve health equity in cardiovascular disease prevention across the life course. Of course, many individuals across the country were part of this team that worked on the CKMH initiative and the Prevent Risk Calculator. What are we trying to do? We want to assess risk, that CPR approach, understand the stages of CKM risk, come back to thinking about the patient, a conversation with the patient, and then longitudinally sharpening and improving upon care. Now, subsequent to the publication of the Prevent Risk Calculator was this paper in JAMA that received a lot of national attention. It splashed big in the news. And in this analysis, the authors extrapolated data from NHANES. They compared the pooled cohort equation and prevent 10-year ASCVD risk, and using a 7.5% threshold to think about a statin or blood pressure medicine, they reported that 14 million people would no longer be recommended to take a statin and 2.5 million no longer a blood pressure medicine, leading to 100,000 more deaths, 100,000 more MIs and strokes across our nation over 10 years. Well, I'm going to tell you, don't press the panic button on prevent. That paper did not evaluate prevent using the optional predictors, which essentially make prevent beyond the pooled cohort equation. They evaluated only 10-year ASCVD risk, not total CVD and heart failure. They didn't use the risk enhancing factors, so they didn't go to the CPR algorithm. And that prevent is a calculator now that is more applicable to diverse populations, improving upon both discrimination but also calibration. The pooled cohort equation overestimated risk for many. And so a key question for the guideline writers in the future will be whether to change that threshold below the 7.5%, because the net clinical benefit for therapies like statins, blood pressure medicines, that actually occurs at a threshold often as low as a risk in the range of 3 to 5%. Well, as I begin to wrap up, we have many silos in care, silos in academic health systems, silos in our approach to the integration between healthcare and public health in our community. So we don't want to be like the blind man and the elephant, right? We need to think about the whole of our patients, the whole of their family, the whole of communities that we have many entrusting their care with us. And then as we move towards the future, this science of precision prevention is a data-driven merger of precision medicine and precision public health. And by integration, we have an opportunity to mitigate health disparities through bringing in many of the measures we have today, systems approaches, electronic health systems measures, but we must think about the social determinants of health and the risk of communities. So take-home points, CKMH to prevent CVD. We absolutely want to promote cardiovascular kidney-metabolic health across the life course. Lack of CKMH is common and concerning. You're now familiar with the Prevent Risk Calculator to calculate 10 and 30-year ASCVD, CVD, and heart failure risk. Risk assessment will always be a starting point. It's not the end, it's the beginning. We need comprehensive and integrated CVD prevention, and absolutely now we have consideration for future guidelines. Really appreciate your time and attention today. Again, it's been an honor. Very grateful to present today in Grand Rounds. I'm going to stop sharing my screen and we'll take some comments and questions.
Thank you so much, Dr. Sperling, for this comprehensive overview of both your career and also the importance of cardiovascular prevention and how it has evolved over time. I welcome, all of the questions in the chat, and also feel free to unmute and ask a question. I'm going to start with one question that I have posed to you in a different forum, but is the same question essentially. And I will tell you that as a practitioner, I have some, the beginning of your presentation really resonated with me, that as general internists who take care of patients and are working on primary prevention, it has been drilled into us that we really, really need to start early in terms of mitigating cardiovascular risk. And however, now that we transition from the 2013 risk calculator to the prevent calculator, there are some groups of patients that we have identified previously as particularly high risk. For example, a younger Black male patient that with the prevent calculator doesn't tell us to initiate treatment. And I have a lot of anxiety about that, again, because I want to invest in this group of patients and ensure that I'm addressing their excess cardiovascular risk. So what advice do you have for practitioners, that are listening who may have to pivot based on transitioning from the older calculator to the new calculator and wanting to mitigate excess cardiovascular risk, but maybe that means that we're actually going to taper back on some of the therapies that we usually provide?
Yeah, so really important comment first and then a question. The comment that's important is our primary care community, pediatricians, family practitioners, internal medicine specialists, OBGYNs are really pivotal in terms of trying to change the trends and curves I showed at the beginning of my presentation in our local communities, but also nationally and globally. Without the primary care clinicians and the health systems integrating with communities and public health, cardiovascular disease will continue to remain the #1 cause of death in the US and globally. So coming back to your question, remember risk assessment's a starting point. And so a young person, they're going to have a low 10-year risk just by age alone. But I like to use a concept of lifetime risk or that 30-year risk. And, when 30-year risk starts becoming 50%, a lot of people, it's hard to conceptualize, oh, I have a 20-year risk, a 20% risk over the next 10 years. A patient might say, well, that's an 80% chance I don't have a problem. But when you start talking about a 50% risk of a heart attack, a stroke, dying of heart disease or heart failure, that gets somebody's attention, right? And in a younger patient, it doesn't always mean we have to start medical therapies early, but we do want to apply those risk enhancing factors. And when appropriate, we want to reclassify risk. And so in that young individual, let's just say they have elevated blood pressure or even stage 1 hypertension. That doesn't mean not treat. So these are going to be starting points, and even our guidelines. Guidelines are there to provide guidance, but they're not the be all and end all. We should have a discussion with a patient, and frequently with a patient after getting to know them well and recognizing that risk occurs over time. I was definitely not a math major, but area under the curve, right? That's an integral. It's your blood pressure across your life, your cholesterol across your life. This is where the impact occurs. We absolutely can make a team decision with our patient about starting therapy. So it doesn't mean ignore until their risk crosses whatever threshold, and then, oh, like now you're at risk, so now we're going to start treating you. We very much need to individualize our care with the guidance of guidelines, with the guidance of calculators.
That's great. Thank you, Larry. And of course, with the new Prevent calculator, some of the estimates of social determinants of health, and I think the robustness of the cohort that your group used, hopefully will be a little bit more reassuring in applying some of these, risk calculators without the use of race. Wendy, I'm going to send it over to you. It looks like your hand is up. Hold on, you're on.
Yes, I got it. A quick and easy question, and then a probably unanswerable question. The first is, I'm like, as an infectious disease person, I'm really happy to see that risk enhancing factors included. We always sit there in front of our patients living with HIV and try and think about how to assess how do you add their risk in and change what you're doing for that person compared to a comparably aged person without HIV. And so I guess the easy question is, but when I pull up the calculator, for example, it doesn't easily link me to something that says, consider these, or how do you measure them in? And I think for someone who may not be tuned into that, that might be lost or missed. Are there plans to sort of incorporate the risk enhancing factors in a way that someone who hasn't delved into this deeply will recognize? And then I can ask my more complicated question.
I think your comment is really important, and I'm going to bring it to the AHA because it's so logical that it's not there. But if you read the papers now, hopefully Grand Rounds will perk your interest and you'll start implementing the Prevent Risk Calculator. But the risk enhancing factors are very much embedded in the guidelines. They're embedded in the papers, but if you don't read them, and you're not aware of risk enhancing factors, it's not front and center, and it should be. So I'm going to bring this to the AHA because it should be linked to that site, and that CPR algorithm should also be front and center. That risk assessment is a starting point and not the end. Now, as you would imagine, somebody asked about triglycerides, as these risk equations are developed, whether it's Framingham or the Poole-Covert equation or the Prevent, many risk factors are entertained and are assessed in terms of the development, the derivation, and the validation. And coming back to that C statistic, the area under the curve really budges very little to almost nothing with using other risk factors. And now, how do you factor in HIV or psoriasis or preeclampsia or an early history of heart disease in the family? You can't do that numerically, but if you're aware of the risk enhancing factors and you calculate risk, so that's the C, and then you start personalizing and saying, hey, my patient has treated HIV, they have a family history of heart disease. And then on top of that, let's just say, for argument's sake, somewhere there was a CRP and it was elevated. It's non-specific, but it's a measure of inflammation. that's a time for you and your patient to begin discussing together how we think about prevention in them, not just in a population that we've calculated a risk score for. But Wendy, I think your comment, it is really important, and it needs to be there on this site. Thank you.
Awesome.
Yeah, thank you so much.
So my second question is, I'm so happy to see the way that you're adding social determinants of health and talking about interconnectedness. In the ID world, we talk about syndemics, that you have, two diseases potentially that magnify each other and then are influenced by the factors in the environment, like social determinants of health. So HIV and hepatitis C and, healthcare disparities and structural racism and all of that. The same is true, I think, for every disease that we have, and heart disease, metabolic syndrome, and the social determinants are absolutely a syndemic, and obesity, et cetera. How do we, it demands a different healthcare system. It demands one that is more interrelated and less siloed, so that we work to, have different access points depending on which piece of that, which disease you have that may, lead to others, and how do we approach the social determinants of health? And so what do you think the future should be, or what's the ideal? Do we reconstruct healthcare to be not siloed, and to, how do we move forward? Because now we can estimate risk and maybe approach, medications or exercise, but we still have to tackle so many other big issues and be looking at patients more holistically.
Absolutely, we need to think holistically for individuals, for families, for communities. If we just practice traditional healthcare, we're missing a lot in terms of prevention, but also opportunities for optimizing health and healthcare. I've shown a slide all over the world related to converging syndemics. Boy, if we didn't learn something through the COVID-19 pandemic, converging syndemics were a tipping point, right? An unwell population with health disparities challenged by an infectious disease. In my public health world, I do a lot of work between the intersection between NCDs and infectious diseases. And not surprisingly, this is really important for us to not only be aware of, but we need to be ready. And then what do we do? Sometimes when I'm talking to house staff in the clinic, I say, wouldn't it be great if we've got a whiteboard right here. Let's just erase our current paradigms of care and let's start all over. And let's start all over thinking about what is it that we're actually trying to achieve. Now, these barriers that we have of silos, we have unique challenges in the US healthcare system, but even in systems around the world where there are national health systems, quote, universal coverage, there's still many silos. And so how do we integrate? We talk a lot about it, but we need to focus on true strategies, and not just action, but impact. And a lot of it is we need to align incentives, and incentives, in part are economic, but we need to think about what are the incentives. We need to align goals. And right now we have so many phenomenal tools that we are underutilizing. And we like to talk a lot about AI, right? So, artificial intelligence, but it's really assisted or augmented. And ultimately AI should be there to improve HI, our human intelligence. So, we are at an amazing time in health and healthcare. And what I'd hate to see is, you're going to invite me back 20 years from now for grand rounds. Carlos, you'll still be the department chair 20 years from now, I hope. And, and I don't want to give this same presentation 20 years from now with cardiovascular disease at the top. There are about 10 countries in the world where cardiovascular disease is no longer the #1 cause of death. And how did they get there? They got there through a true commitment at a national level. Slovenia is one of these countries. The Minister of Health 20 years ago committed to a cardiovascular disease prevention program starting with children across the life course. And so it takes leadership, it takes commitment, and it takes a team. But the gaps we have right now between innovation, science, discovery, and implementation are quite concerning.
Thanks.
Thank you. Thank you, Larry. That's aspirational. So just to close the loop, it sounds like you picked up from Dr. Musa that the triglycerides were looked at and that didn't really have an effect on the calculator. What about LPA? Does that fit in anywhere also? And then a separate question about if you anticipate genetic risk might be incorporated into risk assessment in the future.
Sure. So if you look at risk enhancing factors and read that table, elevated triglycerides might be considered a cardiovascular risk enhancing factor. We now have the development of new unique medications that are small interfering RNA agents that can block intermediary lipid metabolism, lowering triglycerides, and at least from Mendelian randomization studies, we think these agents will also lower cardiovascular risk. So triglycerides are important, but they're not in the risk equation. The polygenic risk score, we have the ability to utilize that. Typically useful in a younger population, but at least now not incorporated into any type of formal risk score. Lipoprotein little a high LP little a is present in 1 in 5 individuals worldwide, very common. And we think it is a causative factor for atherosclerotic cardiovascular disease, not just a marker of risk. We're at an incremental phase right now in terms of science and discovery and pharmacotherapy, so a lot to be learned. RCTs in progress. There is an Lp(a) risk calculator developed in the UK through the UK Biobank. There is a MESA risk calculator, the multi-ethnic study of atherosclerosis risk calculator. You can use the cardiac CT calcium score as a part of that. So I'm not here to say the Prevent risk calculator is the only risk calculator, but it is the most robust and the most intricately developed risk calculator to date. In Europe, they have a Euro score. So I think if anything, assess risk, however you want to assess risk as a starting point. But many clinicians today, don't assess risk and they throw darts.
Well, with that last comment in mind, Dr. Rob's other question I think is helpful, which is, will the current ASCVD app change to the Prevent calculator?
So not for me to answer, and certainly for organizations to determine. The pool code equation is an effort of many organizations together. Not that it's good or bad, but the Prevent risk calculator was developed by the AHA. There are guidelines committees that are convening right now to develop the new blood pressure guidelines, the cholesterol guidelines. And so it'll be up to those sitting at the table to think about where this risk calculator fits, how we provide guidance for others. But for each and every one of you, you don't have to be a cardiologist. You should be assessing cardiovascular risk in all of your patients because it is the #1 cause of death in our nation. And so whatever your care specialty is, primary care clinician, specialist, you will be doing a lot of good for your patient to take away from today's grand rounds, to be a preventive cardiovascular specialist, not necessarily a preventive cardiologist.
That's great. Well, we're right at the hour, Larry. Thank you so much for a wonderful talk and for highlighting this new calculator, your participation in it, and also the importance that all of us across the department engage with this calculator. I think it's really, really important work. And it sounds like stay tuned, more to come as the committees convene to talk about recommendations with blood pressure, lipids, et cetera, and the use of this calculator. Thank you so much.
Thank you.